So we're going to shift a little from our program, and I'm going to be introducing to you our keynote speaker for today. Our keynote speaker is Dr. Jeffrey Lombardo. Dr. Lombardo received his doctorate in pharmacy from the University of Buffalo, where he currently holds a research assistant professor title. Dr. Lombardo is the Associate Director for Patient Safety organization known as Empire State Patient Safety Assurance Network, and his role is to facilitate the organization's participation, logistics, and implementing with participating sites, as well as receiving data and presenting reports and findings. Dr. Lombardo has done a lot of work in medical marijuana, and he is going to bring us a very intriguing and interesting talk surrounding the medical marijuana program. So let's welcome him.
Thank you very much for inviting me. I recently gave a talk similar to this at the University of West Indies in the Jamaica, Kingston, Mona campus, and I'm very happy to be here and kind of elaborate. So in theme of Research Day, I'm going to go into some of the data, but really there isn't a lot of evidence-based research out there. We're going to talk about some studies that have been done in animal studies and cell cultures, but kind of the world that I live in, so oncology pharmacy is kind of my background. I did my training at Roswell Park, and I'm glad that there's a lot of students here. Very happy to see that. So when I have students on rotation, I tell them three things. Number one is you have to understand the disease state. Number two, you have to understand the patient's needs. And number three, you put the pharmacotherapy on top of that. So as a prerequisite from coming from Buffalo, I'm going to require at least 2 questions from students after my talk, because so far this morning it looks like a lot of the faculty has been talking about it. So let's get into this. We're going to talk about the history of cannabis, where we are today, in my opinion, where I think where we're going, some of the strategic areas that I think we're going. And in tune of research, I kind of live in that implementation research space. Kind of a bridge after translational to implementational, and I'm going to talk about specifically some of the safety programs of a grant and a program that we implemented in New York State, and I'm going to highlight at the end with some of the unique collaborations we have between UE and SUNY. So the history of medical marijuana in general, very long history. Before in the common area, we see the data recorded as early as 8000 BC, and if you look through some of the, I was really interested and intrigued to see what is noted here, but it really all kind of has the same common theme that, you know, cannabis seeds and hemp has really been around for textiles. We see some of our first medicinal uses in 2737 BC in China. First evidence of hemp paper. Also in China, and if we look at, you know, United States, some of the Declaration of Independence was written on hemp paper. And this is a very interesting slide to me that looks at, postulated the area where cannabis was all started in Asia and is migrating east and west and south. And down into Africa, around 800 AD, across the Atlantic into South America and into the Caribbean in 1800, and Mexico, and eventually to the United States. So if we go a little further on the history, I'm going to focus in on pretty much the same theme until 1850 with a little bit of American flavor here, that we added this to the pharmacotherapeia of an extract of cannabis, hemp, which was used for many indications. And as you see here, it was listed using for neuralgia, convulsions, rabies, cholera. The formulary and indications were large. And it's interesting that in the United States right now, a lot of the proposed, I say again proposed, indications for this is still really around some of these same indications. So we go into the 20th century, 1900, and the migration of cannabis from the Mexican Revolution, negative stigmatisms were put into play here. in articles, in papers, and the first country that started prohibition was in California. But you see a recent ad here, and if you read the fine print, this may be handed to you. Beware, young and old, all walks of life, by a friendly stranger. It contains a killer drug, narcotic, which turns you into murder, insanity, and death. Dope peddlers are skewed. They will put some into the drug in your coffee or somewhere in the tobacco that you may smoke. So then we start to see some of the political ideas or philosophies or views about cannabis. So then we start putting in some regulatory conditions along with the product with the Federal Bureau of Narcotics in 1930. And what do we do in America when we have something interesting to talk about? We put it in the paper, but then we also make a reality TV or show about this. So in 1936, there was the production Reefer Madness that came out. And originally, this was produced for parents to educate their children about some of the adverse effects of the drug, but it was originally picked up by Hollywood and started this negative effects of what medical marijuana. And as you know, we're talking about this, we're really talking about THC, which is really only one of the components in the plant, and knowing over approximately 120 different constituents. But you know, Delta-9 THC is really the one that's had all the press. 1942, it was removed from the Pharmacopoeia Medical Marijuana Act in 37 and prohibited on a national level. So in 37, we had approximately 25 to 30 states that prohibited it. And in 1970, which is kind of really an interesting point here, is that the federal government made a Schedule I narcotic. Okay, so when something's labeled Schedule I, it's perceived to have no benefit whatsoever. So if someone wants to do research on that or wants to apply for a federal grant, it will not be qualified. And I'll talk about some of the ways that we're dealing with that scenario right now. Because in the present day in the United States, 1996, Proposition 215 came about, where once again, you know, California was the first state to outlaw it. California was once again the first state to medically approve it under certain conditions from a medical healthcare practitioner for seriously ill children. And if you look at, now this slide depiction is back in April of 2016. In the United States, we have 25 states that have legalized it either for recreational or medicinal. So you hear it just those two things, recreational, medicinal. 4 states have it for both. But it goes beyond that, because each state, it's kind of like the wild, wild west. Some of them have jurisdiction for non-psychotropic activity with THC. Some will include both. And we're going to get into some of the reasons why was from this individual. Those heard the story of Josh Stanley and a little individual, Charlotte Figge. So Charlotte Figge was an individual in Colorado that had Dravet syndrome. And on a daily basis, she would have over 100 seizures a day. And so her parents were at the bedside, and they were given her last rites, because a lot of these children don't meet their teenage years. They succumb from their disease and some other indications like Dozo syndrome. So they came to Josh Stanley and his family, and they grew a specific strain. So we hear about strains. So this strain in particular was voided of the THC and at a high cannabidiol only. And it worked for her. It worked for her after the first couple of doses. Okay, so we have some evidence that it works. Kind of, and when I heard the Chancellor speak last evening about the operational data that's out there and the quantitative and qualitative data, you kind of see the stage being set of evidence-based medicine, data, and what's really happening. Okay, because this episode was not only seen with Charlotte Figge. Droves and droves of adolescents were coming to Colorado to get residency because, once again, it's a Schedule I narcotic. They couldn't go across the state lines. So thousands of children are currently being treated there for intractable seizures. And Sanjay Gupta also picked this up as Weeds 1, 2, and 3 series that you can see on CNN. So I heard about this, and I have a colleague also who has two kids, 9, and I want to introduce Caden and Taylor. So Taylor's 15 and Caden is 9 and lives in the same town, a very good friend of mine, and this is their medication regimen on a daily basis. So this is Taylor. She takes 32 doses of medication. For the bit. For the students, the endocannabinoid system, and really our body produces. He landed at the University of West Indies 2 weeks ago. He's on the Mona campus. Hopefully he gets to visit your campus sometime. He's going to be there for 2 years as a research fellowship with the Global Health Institute. These are his 4 main projects that are up and going right now. Clinical Research Center and establishing a centralized data management system. Everything that we say we want to do can't happen unless you have a good data reporting system. I heard earlier that some of the reports were done on paper. That's always a limitation in data quality and integrity. This is really the infrastructure that we want to build out. In antimicrobial stewardship, and once again, this is the NIDA, some of the things that they're interested in, where all the money's available. Some of the 3 questions they asked: variations of strains, marijuana constituents, but once again, we looked at research questions. So we are actively looking at this right now. We know that a mass spec resides on the UE campus in Mona. I don't know what type of equipment you have here, but that would be something that we were going to explore as we go, because one of the things we want to do is we want to develop, validate single multi-analytic assays. Okay, you have a pharmacodynamic effect, something happens, we should be able to do a blood sample, separate it, look at the breakdown, and see what's happening. Okay, so assay development, that's what we do. We do assays. So we'd like to do that at the University of West Indies. Once again, it's harder for us to do that in the United States. Design and conduct exploratory preclinical trials, bioequivalence, clinical research protocols, technical guidance, and eventually a mentoring program. We're very big in STEM and training our up-and-coming researchers. So having some of your P4 students present today was very good to hear. And I'm going to end then, hopefully get some questions, and thank you very much.
You mentioned several other systems in the body where cannabinoids are effective, but you didn't mention the effect on the bladder.
On the bladder?
The bladder. The bladder has cannabinoid receptors too. The urinary bladder, I'm sorry.
Yes.
Yes. And in fact, given the fact that overactive bladder is a very significant thing in this country, and the medication is very expensive,
Yes.
takes a long time before it kicks in, there have been some anecdotal people who have noted that when they use, you know what I'm talking about.
Yes.
All right?
Yes.
So in fact, I'm quite encouraged that there's collaboration with Sony, because
Yes.
perhaps we can now look at how those same tablets or the vaporizers can
Yes.
affect the overactive bladder in a shorter period of time, in a much more cost-effective way.
Yes.
I know that some work on GM Pharmaceutical where
Yes.
that guy went actually was looking at it. And in fact, I think Claire Fowler in Great Britain at the Neurological Institute in Britain, she has also done some work, but then again, their work was actually in patients who had, again, it wasn't very declarative, but their cohorts of patients were actually people with multiple sclerosis, not overactive bladder.
Yes.
Do you see a pathway for us?
I do. very much so. And really one of the reasons for me coming here today, so not only to speak to you today, but kind of plant the seeds, make the contacts for future collaboration. So there is evidence in, I believe, some of the mouse models that the cannabinoids cause an antispasmodic effect. Okay, we know that. Very familiar working with the Dean Horace and Dr. Fletcher. They're very much involved in a cannabinoid research task force, a working group that we've established. I can tell you that some areas from that last slide, diabetes is a concern because really the cost curve of the Caribbean. But once again, we're looking for those, and we don't want to come in here and be the PIs on these studies. We want the University of West Indies to be the PIs, the leading researchers, and what we do, the SUNY is global outreach and telemedicine. We want to help provide the infrastructure. We want to help you write grants and propose that so you can be PIs and you can publish. I remember the principal, Dr. McDonald, when we were sitting in the room with some of the researchers there, he says there's a couple words, it's publish or perish. So that's kind of our mission, to help provide that infrastructure. Right now we're working on the data quality. We know there is a very robust data analytical field line that runs from Kingston to Miami. Okay, and that can be a hub for all the Caribbean. And there's there's that. I'm learning a little bit about IRB. I'm learning a little about the infrastructure that needs to be built. Then eventually, that one about connecting, what I do is I try to connect things. And I try to connect private and public sector together for value with a patient focus. So very encouraged. Please reach out to me, anyone on faculty here, to kind of foster some of these programs. Thank you for the question.
One last question. Good morning.
Hello.
Just kind of interested in like side effects and complications
Yeah.
of marijuana, especially on the young brain after 21 thing.
Yeah.
That there are changes. So are there any studies on monitoring going on now for children or adults who are right now using marijuana in the United States? And any kind of long-term research to look at that?
Good question. So the question was getting onto the safety aspect, the adverse effects as far as brain development. 16 has been the number that I usually quote, up to 21. There are some studies, and is it currently being done in the United States? Tough question to answer. Okay, so it's very hard to get a clinical trial approved looking at that in the United States right now. Most of the work is being done in animal studies. Okay, but we know that that's where it needs to go. And I don't think we can get to that until we standardize the analytical compound that we want to study, because that's not happening. So whether it's through synthesis or whether it's through an isolation of something, if there's a good process, we have to do the preclinicals, we got to do PK/PD, we got to do the animal studies, then we write a trial looking in humans. But you know, there are some in adults for diabetes. I know GW, and if you go clinicaltrials.gov and you look at that, there's a lot that are kind of in the works, but it's,
Especially with them already being
yeah. You have anecdotal.
Thank you very much. An impressive amount of material you presented. I know a bit about the Global Health Institute, but something that worries me, all natural products research is very difficult, as you quite rightly say.
Yep.
What is the point of trying to do clinical trials with a natural product? And if I were the dean here, I would say, until you get the pure substance, don't worry to come and talk to me.
Absolutely.
So the question is, what is the point of doing all these extensive studies on the product that is not pure when you're already well advanced in producing the active principle? Why?
I think there are some things you can do. So when the NIH puts out money to do investigation, some of the trials are written.
Money shouldn't drive you when you have a natural product.
But I can tell you that some of the work is done because there's grant money available, so there's work to be done. But I do agree with you that you cannot go forward until you standardize the compound and where it's reproducible. where it's validated and it's reproducible and ongoing. So I agree with you 100%. And the FDA now with I believe they opened up a new division for FDA approval of drugs that looked at whole plant botanicals. So that's recently in 2015. Now, I'm not familiar with all the guidelines, and we get into nutraceuticals and things like that, but it's a very valid question and a good question. I agree.
Thank you, Dr. Lamada. Thank you. Give him a round of applause. As I'm going to getting ready to invite one of our own, Dr. Corinne Sinqui, who is the lecturer in pediatrics and also a hemato-oncologist, who has really helped spear the project of integrating our campus with Toronto Sick Kids, and we're going to hear about what are the benefits of that. Dr. Sinqui, please.
Thank you very much, and thanks to the organizers for allowing me to give you an overview of what our initiative is all about. The only disclosure I have is that I am the clinical lead here in the Bahamas and have received some funding for conference and meeting attendance. Outside of that, nothing else. This is the outline of the presentation. And I just want to mention that the Caribbean, now this is an opinion, and it's early in the slide, but I wanted to bring it up, that the Caribbean is a very fertile region for twinning. Easy travel access, relatively, I put relatively there, safe and stable environment, English speaking. It's really an untapped population for research. And collectively, if we consider ourselves one country, I see Dr. Roberts has there one school, one faculty, one degree, our Caribbean. And I'm sure that most of us will claim the Caribbean as one during the Olympics. So when you think of the collective population, it really is a very fertile ground for anybody to be interested in a twinning program. So the Hospital for Sick Kids is the largest pediatric center in Canada and one of the world's leading pediatric hospitals. And the Division of Hematology Oncology is among the largest globally and sees 20% of all pediatric malignancies in Canada. And building on existing relationships, we were able to, in 2012, have a memorandum of understanding where the with the University of the West Indies, since it was already stationed in some of the participating countries. In 2013, we signed on agreements in 6 different countries, 7 different sites: the Bahamas, Jamaica, Trinidad and Tobago, St. Vincent and the Grenadines, Barbados, and St. Lucia. Collectively, we are talking about a population of 5 million people. Little Bahamas only contributes 7.7% of that total. This initiative was able to raise 8 million Canadian dollars to fund this. And believe it or not, most of that funding was raised locally. Canada was able to come down with their team, approach certain persons and entities, and ask for money, and got it in our backyard. And I suspect that is because of the name, the fact that they are accountable for what they do. Sick Kids Center for Global Health is the dedicated hub for all global health-related activities there, and our initiative falls within the capacity of the building pillar. The goal of the initiative is to improve outcomes for children with cancer and blood disorders in the Caribbean through increased application of best practices inpatient management via clinical care guidelines and training, increased use of data to improve clinical outcomes using evidence-based information, improved access to diagnostic services, and an increased academic visibility via research and publication. 6 working groups were established, and each of the working groups had a co-lead from the Caribbean and a co-lead or members from SickKids. And the 6 working groups were charged to develop work plans to enhance infrastructure, training, strategy, and advocacy in our Caribbean region. These groups included diagnostic services, nursing education, cancer registry, clinical care, sickle cell disease, and research and evaluation. So, how did we benefit from it? The first thing that we thought about collectively was that maybe we should establish the telemedicine units, and we were the first one to get our unit started. And this was established in July of 2013 to help the delivery of our case presentation and patient education. We received other donations as well in the form of a computer, laptop computer, and a printer from the Rotary Club. And the Bahamas, up to March of 2016, submitted 18 cases for consultations, and these were presented in some way or form via the telemedicine unit. And you will see that the distribution of the number of cases is as per the table. So we had our fair share of representation there. As was expected, the number of cases that would have been submitted were mainly leukemia, lymphoma, and solid tumors, because that's where, with limited resources, you need extra input from these world centers to help to guide us with regards to input. 66 of these cases were submitted for specialized studies in immunophenotyping and cytogenetic studies, and 2 of the new leukemia cases came from the Bahamas for this. Clinical care and supportive care guidelines were also developed, and these are the 8 that have been completed and circulated to be used. And the aim for the initiative is to try and produce standardized documents that we can use as the basis and guidelines for what should be the expected care. We realize that there might be some variation from site to site for the delivery, but at least you have a framework from which to move. Several others are in preparation. This is an unpublished study that was done by Dr. Williamson for her DM thesis, and in that study at PMH, we were able to establish that the incidence of cancer is 8.3 per 100,000 in children, and this translated to 5 to 16 cases per year, with a mean age of diagnosis of 9.15 years. Leukemias, brain tumors, and lymphomas with soft tissue sarcomas were the leading tumors. The cancer registry, as I'd mentioned, as one of the working group, was established to continue the collection of data, because we figured that if we were able to get the information for the region, maybe we'll be able to use that to help to generate decisions with regards to things like procurement of drugs. Putting resources in strategic places and having different countries target the resources so that we actually work together as a region and not individual countries, because as individual countries, our population really is not that great to sustain everything. And I think this is one of the success stories for the Caribbean. I think the University of the West Indies is one. I think that CARICOM is supposed to be one, and I think that it has the potential to be a big one. The OECS, I think, is a good one, because I think with the OECS, with their countries, 9 countries, they're able to do some of this collective bargaining for purchasing. And I think we as a region need to probably move to that. So the cancer registry, we have collected information on 339 cases so far, and this dates back to 2011. They would like to go further back, but they had to have a starting point. So we are moving forward and trying to get at least the information back to 2011 and to be able to look back at it and see if there are any obvious observations that require attention. We have entered 44 cases, that is 13% into the registry already. As you might be aware, the National Cancer Registry Act was passed just recently, and this, in fact, mandates that every cancer case has to be reported. Because we already have the registry in place, we are going to be able to transfer that data collection directly to the National Cancer Registry. But I think that this registry that we're keeping with the initiative is important to keep separately because we are part of the collective group. With regards to training, the oncology nursing certificate course started in September this year. It was specially designed in collaboration with the University of the West Indies and the Sick Kids group, and it is stationed in Trinidad. 2 of our pediatric nurses have already departed to start that training, and we have 2 more slated in the next cohort. I think it's in January. 3 of these are funded by the Sick Kids Initiative. Laboratory was not forgotten. We do have them on the list as well, and with the laboratory services, they have initiated immunophenotyping services in Jamaica with support there. We're not big enough to do the immunophenotyping here. We just don't have the number of cases at this point in time. But we are looking at the other things. So hemophilia workshop was attended by one of our young laboratory technicians, as well as 1 junior physician from the Department of Pediatrics. And several international conferences and workshops were attended by nurses and physicians. Here's the money. I mentioned to Dr. Johnson that now that I can show him that it's not always that I ask for things, but sometimes we give back things. So I think I have credit for almost $350,000 to ask him for anything. This is the breakdown. The BTC telecommunication room is a donation that is $100,000 over a 5-year period. And many of you have had the privilege of sitting in and benefiting from that room. So even though it was generated for the initiative so that we could make the connectivity for case consultation and teaching, it's actually open for use for other things. And when we talked about it in the Caribbean group, we felt that if nothing else, if everything else failed with this initiative, we would each have had our telecommunication rooms. The training for the nurses is about $10,000 if you take into consideration the assistance with travel and accommodation. So that's $30,000. Each case consultation is about $850, so that's the physician side, pathology review, radiology review. And to date, we have submitted 26 cases for review to the initiative. Laboratory, we haven't utilized this as much because we don't have that many cases, so we only have $3,000 there. We actually get a stipend to pay the support for the telecommunication room and the cancer registry. So collectively, that's $75,000 that is being inputted into our system. The travel for the training, $26,000. And there was one child via the initiative where we were able to access the Herbie Fund in Canada to have a child have a brain tumor removed that was deemed not operable over here. I put that figure to 30,000. And then there was a special medication that we were able to receive via the connections with Sick Kids consultant that would have, if we had had to purchase it, cost $60,000. So in the pediatric department, we have a fund of $350,000 thereabout, Dr. Bassett, that you can request of Dr. Johnson at any time. There are some non-financial benefits to this program, though. The access to the consults and resources, that's just priceless. The guidelines that are being developed, priceless again. Via this initiative, we are going to be on the global stage because they've already started producing abstracts and papers and presenting at international conferences for the work that is being generated through this initiative. And special, even though it sounds impossible to say this, they've actually caused us to talk to each other. So the inter-Caribbean collaboration, again, priceless. And the facilitation of education and training, of course, is a plus. Challenges, short time frame, they have to demonstrate that you can produce results, that you are accountable, that you have measures of success and planning for long-term success. So there are going to be some challenges. However, I would like to be able to know that at the end of this 5 years, we have our nurses trained. We see more of the new SOPs develop. Hopefully, we'll be able to embark on newborn screening for sickle cell disease and partner with a site like Jamaica that has a special unit that can run our newborn screening at a lower price than what we can do it for here. And I definitely would like to cash in on the one slot in 2018 for HEMONC fellow to be trained because I need somebody to replace me. And this initiative has also opened other twinning opportunities, and right now we are looking to, at an opportunity to twin with the American Society of Hematology for further collaboration. We have been lucky. We have been able to partner with an international organization whose reputation is beyond reproach. And in so doing, we have been able to get funding needed to make this initiative a success. In the short time, the Bahamas and the other 5 countries have benefited greatly. So even though I started out by saying the Caribbean is a fertile ground for twinning, I think we have to be very careful with who we twin with, because you realize that our reputation is going to be at stake. If you twin with the wrong person, then all might be lost. But I think for this time, we actually have a wonderful model. And when they approached us initially to ask how this could work, we thought that going through the governments might have been a little bit more testy with regards to the red tape. And so we suggested that maybe it could be done through the university, which actually had the linkages already in a lot of the countries. That is the model they took, and that is the model, I think, that has brought us to the point we have. Thank you very much.
Are there any questions for Dr. Sinqui? Dr. Chin, please, by the mic. We want to record.
Dr. Sinqui, thank you. We seem to be overrepresented. Do you know why we might be having that? Our cancers seem to be a lot more than compared to the other countries per capita, I mean. How do you account for that?
You're talking pediatric cancers? No. No, but remember, they're just starting to collect the data. I'm just reporting what is already inputted in the registry. So all of the information is not there as yet. So this is an interim report that I am presenting. So it's ongoing, but we did have at the last AGM information that we have to be looking at, early deaths. What can we do to prevent that? Which sites are actually having the problem? So there are some alerts that we have already just from the limited cancer registry information.
Is there one type of cancer that is more represented here?
No. Just from Dr. Williamson's thesis, we were able to highlight that we have soft tissue sarcomas more so than we would have expected. And the other thing that was different from other international sites, and Trinidad is the only one that we found information on for incidence of cancers, was the variation with AML and ALL, which I had put in the previous slide, but I didn't highlight that because we didn't have much time. But if you look at this, the ALL to AML ratio is 2 to 1, and that's high. Okay, so that might also explain part of the reason why our mortality rate and 5-year survivals are not reaching the international figures. And I was just sharing with Prof. Reed that in the past month I have 5 new cases that I'm looking at. 2 Hodgkin's, 1 osteogenic sarcoma, likely hepatoblastoma, and a brain tumor. And this is in 1 month. But then again, it might be skewed because I haven't had any other cases up to now for the year. So this is my 5 and a couple more expected. So you expect somewhere a region of about 10 new cases per year, and that would fall in the expectations for the numbers. So we have to look at it. And with us, we are a small country with a small population. It will take a lot of time before you can really say definitively that our incidence is rising, our cases are unusual. Thank you.
Thank you very much, Dr. Sinqui. I myself am one of the beneficiaries of the teleconference room. I invite now Dr. Candice Bannister, who's presenting in place of Dr. Brianna, sorry. Temporal trends in the incidence of Staphylococcus aureus bacteremia at a teaching hospital. Okay.
All right, good afternoon. My name is Dr. Diana Bannister, and it is my pleasure to present the following study looking at the temporal trends in the incidence of Staphylococcus aureus bacteremia at a teaching hospital in Nassau, Bahamas, between the years 2012 to 2015. Staphylococcus aureus is a highly virulent pathogen and major cause of bacteremia in both community and healthcare settings. Studies have shown that it accounts for 20% of all healthcare-related bacteremias. Staphylococcus aureus bacteremia is associated with significant morbidity and mortality, with the mortality ranging from 20 to 30%. When associated with infective endocarditis, the mortality rate is even higher, ranging from 19 to 65%. And in a review of the literature, a large prospective study showed that Staph aureus bacteremia was associated with 34% of cases that developed into metastatic infections. So we conducted a 4-year retrospective study describing the epidemiology of Staph aureus bacteremia at the Princess Margaret Hospital. Patients 18 and older with first-time Staph aureus isolated from blood cultures were identified using the lab's microbiology Sunquest system and medical records here at the Princess Margaret Hospital. Acquisition of Staph aureus bacteremia was classified using the Friedman model into nosocomial, healthcare-associated, and community-acquired. Temporal trends of Staph aureus bacteremia were described in regards to age, gender, acquisition, and susceptibility patterns. So the objectives of the study were to determine the prevalence of Staph aureus bacteremia in patients at the Princess Margaret Hospital, to describe associated demographic and comorbid risk factors, to determine the prevalence of methicillin-susceptible and resistant strains with regards to acquisition, and to determine 30-day mortality rates with regards to methicillin-susceptible and resistant strains. So what did our results show? So it showed a statistically significant increasing trend of 4.4% per year in the prevalence of Staph aureus bacteremia. And the range was from 8.66% of all positive blood cultures in 2013 to 11.54% of all positive blood cultures in 2014. This graph here demonstrates that for each year in the study, that the proportion of males outnumbered that of females with Staph aureus bacteremia. And in this graph, we stratified Staph aureus bacteremia by age. And the results demonstrated a consistent trend in prevalence with regards to the age categories. Specifically, the 40 to 59 age group was statistically significantly higher than the other age categories. And here we looked at the prevalence of Staph aureus bacteremia based on methicillin susceptibility. And we found that the prevalence of methicillin-susceptible Staph aureus was statistically significantly greater for each year in the study period compared to that of the methicillin-resistant Staph aureus, as well as the prevalence of methicillin Staph aureus ranged from 55.67 per thousand in 2013 to 95.89 per thousand in 2014. And that of methicillin-resistant Staph aureus ranged from 17.96 per thousand in 2012 to 35.37 per thousand in 2015. When we looked at Staph aureus bacteremia in regards to acquisition, specifically nosocomial, healthcare-associated, and community-acquired, we found that healthcare-associated acquisition of Staph aureus was statistically significantly the most prevalent acquisition type for each year in the study period, and that's demonstrated by the orange bars. When we looked at clinically relevant comorbidities in these patients with Staph aureus bacteremia, specifically diabetes mellitus, congestive heart failure, end-stage renal disease on hemodialysis, HIV, malignancy, COPD, cirrhosis, stroke, and injection drug use, we demonstrated that for each year, diabetes mellitus and end-stage renal disease on hemodialysis were the predominant comorbidities. So with regards to identifying a source of bacteremia, and a documented source would include line or endovascular source, a respiratory source, skin and soft tissue infection, intra-abdominal infections, central nervous system sources, other sources, and unknown sources. And what we found was that for each year, no identifiable source was documented in the majority of cases. With regards to 30-day mortality for Staph aureus bacteremia, in 2012, the 30-day mortality rate was 22.22% of cases, 30.95% of cases in 2013, 32.3% of cases in 2014, and 29.69% of cases in 2015. And although the 30-day mortality rate is high, there has not been a statistically significant increase in trend. And when we looked at 30-day mortality with regard to susceptibility and resistant strains, methicillin-susceptible Staph aureus was found to be more prevalent compared to that of methicillin-resistant Staph aureus for each year of the study. However, when we looked at the proportion of persons that died, we found that the proportion that died from methicillin-resistant Staph aureus was greater at 39.6% compared to that of methicillin-susceptible Staph aureus at 25.7%. And this corresponds to an odds ratio of 9:1. And thus, there's a 9 times more likely chance of dying from methicillin-resistant Staph aureus compared to that of methicillin-susceptible Staph aureus within the study period. So, in conclusion, the prevalence of Staph aureus bacteremia at the PMH is high and demonstrates increasing trends. There was a higher proportion of males than females for each year. The 40 to 59 age group were significantly more prevalent. Healthcare-associated acquisition was statistically the most dominant acquisition type. The prevalence of methicillin-susceptible Staph aureus was significantly greater than methicillin-resistant Staph aureus for the study period. Diabetes and end-stage renal disease on hemodialysis were the most common comorbid conditions we saw among patients for each year. That source identification was unknown for the majority of cases for each year during the study period. That the 30-day mortality from Staph aureus bacteremia is high, though the trend itself has remained unchanged statistically. And finally, although more persons died within 30 days from methicillin-susceptible Staph aureus, the odds of dying from methicillin-resistant Staph aureus was 9 times greater. So what do we hope to achieve with this study? Well, we want to increase the awareness among the physician body and other healthcare workers to the virulence of Staph aureus. And we also want the physician body and other healthcare workers to appreciate that bloodstream infections are a completely different clinical syndrome compared to localized soft tissue infections. Okay, particularly bloodstream infections involving Staph aureus. They're associated with much morbidity, much mortality, and there must be the appropriate and timely use of bactericidal, not bacteriostatic, bactericidal agents with appropriate and significant duration to treat these infections and thus minimize long-term complications and mortality. We also want to encourage investment in laboratory equipment that would identify organisms and their susceptibility in a faster time frame. Current technologies now can actually report on susceptibility within an hour of receiving a blood culture sample. Currently at our institution, sometimes we have to wait upwards to 72 hours to get susceptibility reporting and identification of organisms. So we need to invest in the technologies to do so. And just to end, that studies have shown that appropriate consultation with an ID consultant or ID specialist has been shown to show greater source identification, as well as a decrease statistically in the morbidity and mortality associated with Staph aureus bacteremia. I thank you kindly.
Are there any questions for Dr. Bannister?
MRSA in all the blood cultures. You looked at just positive blood cultures, but you didn't look at all the blood cultures that were done in terms of, is our MRSA incidence rising?
Okay, so to answer your question, Dr. Chin, we looked at 1,752 blood cultures, okay, all that were positive for any organism, okay? And of that number, we stratified those that were positive for Staph aureus.
And how much do you say the MRSA was?
Pardon me?
The incidence, the prevalence of MRSA?
So the prevalence of MRSA? What are you asking?
30%.
Right, so our study showed a prevalence between, I think the lowest was 22.2 and the highest was 32.2. And if you remember from the first slide, it actually mirrors what has been done in other studies in other tertiary settings, that the prevalence is between 20 and 30%.
Dr. Reed.
That's
Very nice
Staph aureus.
presentation. Thank you for
Okay.
a very good presentation.
Thank you.
I presume that a lot of the people with end-stage renal disease were on dialysis, hemodialysis.
Yes.
Were studies done as to the association between the hemodialysis and the infection? In other words, was infection prevention and control involved in investigating those infections?
Well, we did not do any statistical analysis in regards to that aspect. But of course, we all know that persons on hemodialysis and receipt of hemodialysis have increased clinical risk factors that put them at increased risk for Staph aureus bacteremia. So that's the presence of indwelling prosthetic intravascular devices, intravascular procedures, invasive, etc. So, but we did not look specifically at that.
Right. And I think your point about early aggressive treatment with bactericidal agents is very important.
Yes.
That when you get an isolate of Staph aureus, don't wait for the sensitivities. It's vancomycin until you know better.
And just to kind of piggyback on that, when we were actually collecting our data, we found that in some instances, persons were using bacteriostatic agents to treat Staph aureus bloodstream infections like Bactrim. Bactrim is a bacteriostatic agent. It is not per guidelines, the Infectious Disease Society guidelines, to treat Staph aureus bloodstream infections. And I also want to reiterate as well is that we need to be aware as a physician body of the virulence of this pathogen. We need to be aware that it's important to have source identification, because once you have source identification, then you can have source control. And we also need to be aware that it's important to initiate appropriate bactericidal antibiotic management as soon as possible.
And appropriate investigation, because
Right.
bacteremias have a high incidence of endovasculitis as well as valve infection.
Exactly.
That might increase your 30-day mortality if your treatment is long enough and appropriate.
And just to piggyback on that, every person that has a confirmed Staph aureus bloodstream infection should have a 2D echo.
Last question, Dr. Sawyer.
If ESRD patients on dialysis, in fact, the second largest group,
Okay.
it should be easy for you to go and look and see how many of those patients had catheters and how many of them were diabetics, because that's very important. Catheter-related infection in dialysis patients is a different disease from catheters in ICU infections in ICU patients and in patients who are have ports for malignancy. And I think that's we, like other places, have a very high incidence of patients on catheters. And I don't think we do a good job of treating them properly.
Yeah, and once again, to piggyback on that, it again goes back to source identification. Because when we went through the charts, like as the data showed, a source was not identified. So as to whether the person had a catheter in place, et cetera, or some kind of prosthetic device. So once again, it goes back to the importance of source identification when trying to manage these bloodstream infections.
Thank you. Wonderful. In interest of time, we're going to stop. After. Thank you. Thank you, Dr. Roberts.
So a quick outline. In 2002, 1.5 million hospitalizations and 9.1 million doctor's visits yearly was related to urinary tract infections. UTI is one of the most frequent reasons for consulting a GP or a family physician in the community. A meta-analysis by Mason et al. Found that 150 million UTIs yearly cost $6 billion in direct health costs. This high price to healthcare has lent to great consideration to the treatment of UTIs worldwide. An increased antimicrobial resistance usually complicates UTI treatment, leading to increased patient morbidity, cost, retreatment, and the use of broad-spectrum antibiotics. The Infectious Disease Society of America's guidelines suggest that Bactrim and nitrofurantoin for short courses should be used for empirical treatment. However, emerging resistant patterns in both America and European countries has caused great concern for empirical treatment being used and generalized around the world. The IDSA, as well as the European Society of Microbiology and Infectious Disease, have created a threshold of resistance of less than 20% to establish the confidence in guideline-approved empirical treatment. Similarly, the WHO has also suggested that we look at local data and antimicrobial incidence and prevalence in order to better understand our own local uropathogens and to have our own locally guided guidelines.
In Rwanda, high resistant rates to E. coli, which is one of the most common uropathogens in UTI, was found to be to some of the most common antibiotics, such as nitrofurantoin and ciprofloxacin, and they could no longer be used in their empirical treatment. They had to update their national guidelines, and they focused on research in the primary care setting after the study was done. Orat et al. Did some studies retrospectively looking at uropathogens and patterns of susceptibility between 1996 and 99, and he found there was significant changes at that time. Although E. coli remained the most common uropathogen, he found that there was high resistance to ampicillin and augmentin, and he did this study again in 2003, and there were no further studies in that region. Between 2002 and 2013, there were 2,000 patients admitted to hospital for urinary tract infections. However, there was no data available on community-acquired UTIs, and there was no local guidelines for empirical treatment. The aim of the study, therefore, was to look at uropathogens and the antibiotic resistance in patients with community-acquired UTI in New Providence, Bahamas. The objectives were to determine the species of uropathogens found in positive urine cultures in the study population and the resistance patterns produced, to determine which antibiotics were being used by the community physicians, and to determine the socio-demographic factors that might influence antibiotic resistance patterns in the study period. It was a cross-sectional observational study where we also linked microbiology results, and this was done between September 2015 and January 2016 at the following clinics. Our inclusion criteria were symptomatic patients, as well as those who had been diagnosed by the treating physician, who had given informed consent, and who were of the ages of 16 and above. These were our exclusion criteria. And data was collected by a patient questionnaire. We looked at the demographics of the patient, as well as clinical information related to urinary tract infections. And we also took our urine culture reports as a part of that. We use an MSU culture via the PMH collection protocol using a BV vac container. The samples were sealed and stored and daily collected and processed at the Princess Margaret Hospital. The information was entered into SPSS, backed up and stored, and we used statistical calculations with a 95% confidence interval and a p-value for statistical significance of less than 0.05. There were 109 participants that fulfilled the criteria, and the mean age of those patients was the age of 46.19. 14% of our patients end up being male, and 86% were female. Within the group of women, 7.4% were pregnant at the time of the study. And we see that in terms of their marital status, that 70.6% of the patients were single, 20% were married, and 5.5% suggested that they were divorced or separated. In terms of employment status, 61.5% of our patients were employed, 14.7% were unemployed, and 22% reported as retired. Our income status, we see the majority of our patients were making less than $20,000 a year, with a percentage of 77.1%. Of our female patients, 20% were menopausal or postmenopausal during the time of the study, and we found that there was a significant relationship between menopausal status and positive urine cultures, with 61.6% of premenopausal women having a positive culture, and only 27.8% of our females who had gone through menopause or were going through menopause having a positive culture at that time. Although over 60% of our participants were sexually active, only 21.1% of these patients used any form of contraception, and the contraception of choice was condoms, which was 69.6%. Overall, 56% of our patients had had a previous UTI within the following year to this current diagnosis. Looking at the use of antibiotics, over 80% of our patients received antibiotics on this encounter, and 44% of them received Bactrim, 28.3% ciprofloxacin, 20 Augmentin, 13.8 got of various other drugs, but only 1.3% received nitrofurantoin. Although Bactrim was the most commonly used antibiotics, we can see that they were actually prescribed for about 7 days for most of the antibiotics, and so there wasn't really a very big distinction between the duration of time that the antibiotics was prescribed. We also found that the majority of men received ciprofloxacin, and there was a significant relationship between being male and receiving ciprofloxacin in the study. When we looked at the frequency of symptoms experienced by our participants, the majority of participants were found to have frequency, which was 59.6%, followed by back pain, abdominal pain, dysuria, and foul-smelling urine. Out of our cultures, 60% of the cultures were found to be positive with single isolates, and we broke that down by culture type and species, which 24.8% was due to the E. coli species, which was 42% of all positive cultures. The table here shows a relationship between the symptomatology and positive culture status, with highlighted dysuria, back pain, frequency, and malodorous urine, all having a positive relationship to positive culture status. The table here, although quite a bit here, was just an overview of all the antibiotics that was tested, and the highlighted ones, which we will go into in the next table, were the ones that showed very high resistance and were also of some clinical importance. So we can see here that ampicillin, Bactrim, tetracycline, Bactrim, ampicillin, and ceftriaxone all had high percentage of resistance within the cultures that were studied, and we see that ciprofloxacin and levofloxacin had high resistance rates in E. coli. However, their overall resistance rate was below threshold of 20%. When we did a multivariate analysis, we showed that sex, employment status, frequency, and back pain were all positive predictors of a positive culture, and we use that further in our algorithms. So therefore, the patients overall were mostly female, low income, sexually active with high rates of occurrence. There was strong association between sex, employment status, sexual activity, and premenopausal status. Other studies also found similarly that sex, low income, and past history of UTIs, as well as sexual activity, was important in looking at a positive culture. And also, we found that Amaru et al. Found that immunocompromised status was also a factor, however not seen in this study. Premenopausal women were more likely to have a positive culture, and studies have found that that is due to the menopausal status, and the changes of estrogen would lead to changes in flora, which affect the etiology and the culture of the status. E. coli was found to be our most common uropathogen, and multiple studies have concluded that as well, with E. coli remaining between 33% and 90% of all cases worldwide. There was a high resistance for Bactrim overall, with E. coli especially, and Gupta et al. Found similarly that his rates were 18% to 22%. And he found that the poorer bacteriological and clinical outcomes were found when Bactrim was used at these rates of these therapeutic levels. The antibiotic choice were consistent with international guidelines except for the duration of therapy, and this may be due to prescribing practices of medical doctors that are found worldwide to be the driving force of antibiotic resistance. McEwen et al. Went further to say that 37% of physicians in the United States use Bactrim for an average of 8.6 days, which was similar to the increased length of time that we saw in our study of 7 days. And basically that inappropriate prescribing practices were the driving forces as well here for resistance among pathogens in some of the most common infections such as UTI. Ampicillin, Augmentin, ceftriaxone, tetracycline, Bactrim, and Ampsump Bactrim all had a threshold of greater than 20%. And basically from this study, it is suggested that they should not be used in empirical treatment if we were to go by the international guidelines. Ciprofloxacin and levofloxacin, as well as nitrofurantoin, were all with acceptable overall. However, this was found similarly in studies that found nitrofurantoin was effective first-line therapy for UTIs, and we see also with Gupta et al. That there was low resistance for fluoroquinolones in his study. E. coli resistance, however, was high for ciprofloxacin, and we see that with Ali et al., who also saw resistance for varying strains of uropathogens with ciprofloxacin. And in his study, he also concluded that resistance was due to irrational and inappropriate use of antibiotics. Males in the study were treated appropriately with ciprofloxacin, and we see that with males it's usually a secondary cause for urinary tract infections, and we find that the use of ciprofloxacin is usually warranted in those cases. Similarly to us in the multivariate analysis, Mac, Isaac et al. Also used frequency file starting unit and a positive dipstick to create algorithms which he used then in a clinical setting to reduce unnecessary use of antibiotics and drugs for acute cystitis. These were my study limitations, and basically it was a very small population and it required quite a bit of funding. And so in conclusion, the most common uropathogens showed high resistance, especially E. coli. Bactrim was commonly prescribed, followed by Cipro and Augmentin. Bactrim and Augmentin were not recommended by this study for empirical treatment. Nitrofurantoin remained first-line therapy, and prolonged prescription periods may have led to higher levels of resistance. Our recommendations that we review physician antibiotic prescribing practices, to evaluate the empirical treatment here in the Bahamas, and to look at routine surveillance and resistance patterns over time. We'd like to continue future research to create algorithms and guidelines and provide community-based physicians, such as family physicians, with the appropriate knowledge about the most effective empirical treatment for UTI. Acknowledgements and some of my references. Thank you.
Questions for Dr. Archer?
Thank you. Excellent presentation. When you looked at the drugs that we've been using first line, I have a feeling, but I just wanted to be, fleshed out in terms of costs and accessibility of Bactrim and Cipro and nitrofurantoin. If that's going to be first line, where does that fall in terms of costs and availability of that antibiotic in our setting?
So for the study, I didn't look specifically at cost, but like you said, Bactrim is one of the cheaper options, and we see that is one of the ones that is actually supposed to be first line in terms of empirical treatment. So we have a lot of people using Bactrim. Nitrofurantoin, of course, has a lot of side effects and is not as widely used, but this is a common problem that's all over the globe where, we're kind of looking at, we're using these specific antibiotics over and over again, and we're seeing higher and higher patterns of resistance. So we have to think about it this way. We're either going to be treating people multiple times, and then that's a cost factor as well, or we're going to have to look to other medications and make those ones more available, and that might drive the cost down. So it's something that we have to look at in terms of availability, cost, and kind of find some type of medium ground for something that we can use commonly that will also be cost effective. But we're kind of running out of options as we continue using the very common antibiotics over and over again.
I really liked your study, especially since it was community-based. And you mentioned Dr. Orritt's study, it's a lot. However, with the increasing use of ciprofloxacin, we are seeing in the Caribbean, because the Caribbean Association of Clinical Microbiologists do track resistance in the Caribbean, and we are seeing an increasing level of high resistance to ciprofloxacin. So although it is still working for us, I admonish us to try to, as much as possible, back away from the fluoroquinolone, Cipro, along those lines because of that increasing resistance patterns that we're seeing. And to really, try as much as possible to, if you can, go ahead and treat based on your culture sensitivities.
So Cipro is not first-line therapy. It shouldn't be, at least. I know a lot of people were using it previously, and we saw the resistance levels go up. And if you looked at one of the graphs, you can see clearly that for E. coli, which is actually the most common, it's actually about 22%. So it's really not going to be your first-line drug. It's something that you're going to use after you've already got your cultures, or the person has a complicated infection. So Cipro would not be a first-line drug, but as you can see, a lot of people were still using ciprofloxacin in the community.
Last question by Dr. Frankson.
Dr. Archer Cartwright, were you approved by the Ethics Committee to also do this study in other settings than the community setting?
Sorry, say it again.
Were you approved by the Ethics Committee to do this study in other settings other than the community setting?
Well, my application was basically to do it in the clinics setting. So I would assume that because one of the clinics actually was a PMH clinic, that it might be possible to do it elsewhere, but it'll have to be within the public system, because that's what I got approved for.
For some reason, I thought you might have been approved to also do it within the PHA system rather than...
Right, yeah. Well, the PHA system, because I had to go through PMH to get family medicine involved, so they actually approved it for the PHA system.
Yeah.
I did it, though, based in the areas that were clinic affected, although I didn't put it in here. I looked at the rates for emergency department as well as the ambulatory section here. I didn't include it in the study, but I looked at those numbers, and they were quite similar to what I was finding out in the community in terms of outpatients coming in.
Thank you. And just one other little point. This is for all residents. Whenever you're presenting, you're not doing your exam, you're not defending your degree anymore. So that nice list of primary ones that you acknowledge, please put them as co-authors on your front slide. You're not in an exam setting anymore.
There were a lot of people, Dr. Frankson.
I know, but there was a primary set of people that do that. And I think a visiting lecturer pointed that out last year, and we made the same point, and I noticed that most of the resident papers do not have the co-authors at the front. They still have the acknowledgement list. You have grown up now, you have graduated. You please, act in that kind of way as you do that. I noticed a previous presenter was very gracious all the time through her presentation by saying we, because it really was a collaborative effort. And not picking on you, but just taking the opportunity to make a statement for all our presenters who have come through with the guidance of faculty members.
And he was one of my advisors, so
Thank you, Dr. Arch.